Good morning. I am Dr. Sean Coomer, transplant surgeon and Associate Chief Medical Officer here at the University of Kansas Health System. I'm filling in again for Dr. Stites this week and for this monthly edition of Show Me the Science. Today we're learning more about special heart implants that pump your blood for you. They're called VADs, or ventricular assist devices. Specifically, we're talking about LVADs, or left ventricular assist devices. And for people whose hearts are failing, these implants can either help them hold out for a heart transplant, as in bridge therapy, or help their heart keep pumping for years as destination therapy. Today, we're meeting a man who has lived with the device for 6 years and counting. And instead of a typical heartbeat, if you put a stethoscope to his chest, it sounds a little something like this. So not the typical lub-dub that we're all taught about in medical school or nursing school. It's sort of a constant whir. And we're going to learn a little bit about that today. We have a full desk joining me today. Larry Brown is here to talk about his LVAD. LVAD patients cannot do it alone, which is why we're also talking with Larry's partner, Beverly Santos. Thank you both for being here.
Thank you.
I'm also joined by fellow surgeon, Dr. Matt Danter. He is, this is a mouthful here, so he is the Surgical Director of Cardiac Transplant and Mechanical Circulatory Support for the health system. He handles a lot of LVAD surgeries, and today he'll also help add some context to a recent recall of these devices. Finally, and perhaps more importantly, Ashley Manning is a nurse LVAD coordinator, and we all know they're the lifeblood of this entire procedure. And that means that she's the go-to resource for patients living with these devices. If a patient has a question or problem, they call up an LVAD coordinator like Ashley. Welcome.
Thank you.
Larry, we're going to start with you. Can you take us back to 2018, right before you got your LVAD? How did you find out that you were in advanced heart failure?
Well, my injection fracture was up at 15 and was supposed to be at 50.
Okay.
And so after that, they told me, I came to KU and they checked me and said, then they decided to keep me. And then I had surgery right after that.
Right, so it was 15 and it was supposed to be about 50%.
Yes.
Beverly, what did you notice about Larry's energy before he got the LVAD?
I noticed that he was really having a problem, like walking and getting out of breath, just short distances, or just things that he was doing, even trying to lift stuff. It was like he was tiring out real quick. Mm-hmm. And before he came to KU, we actually took him to Providence. Mm-hmm. And, you know, they checked him, and I guess he was there for maybe 3 or 4 days. Wasn't really much they could do. Mm-hmm. And that's how we found out the injection fracture was at 15. We brought him home, but that evening he wasn't feeling good, so we came to KU.
Okay. And over what time period, prior to his LVAD, did you notice all these symptoms you're talking about?
I would say, I'm sure it was a good 3-4 months. I noticed a decline in how he was, you know, not doing well. He was still working and doing what he had to do, but I just noticed he was tiring a lot faster.
Yeah. Dr. Danter, LVADs are for people with advanced heart failure. Can you help us understand what an ejection fraction of 15% means and how that would make somebody feel?
Sure. So just as you were describing, I mean, how patients tend to feel when their EF starts to decline as they get more fatigued, short of breath, and it's very telling because the timelines sometimes are different in terms of how you perceive them. So just like you said, Beverly, you noticed it for 3-4 months. You're like, I thought I just went in and I was fine, and then I wasn't. But what it really means, it's a relatively crude measure, the ejection fraction, that measures the amount of blood that's in the heart at the end of when the heart relaxes, and then how much is left in the ventricle when the heart contracts, and that's a ratio of those two things. And normal is around 55 to 65%. So as you can imagine, 15% is significantly reduced, and that's not atypical for the patients that we end up seeing in so-called advanced heart failure, which is what you're describing. But basically, those symptoms are all pretty typical for people with failing hearts.
So what are the risks when somebody has an ejection fraction of 15%? What can happen?
Well, the most common prodrome we see is what you're describing, is sort of progressive heart failure where you're more and more swollen, more short of breath, more fatigue. But there are some pretty sort of acute problems that can happen, first of which is significant bad arrhythmias. So your heart, because it's so dilated or sort of dysfunctional, it can have abnormal heart rhythms, which are life-threatening. And then the other thing too is when it doesn't pump properly, the blood doesn't exit and eject properly from the heart, so it pools and you can get clots that form inside the heart, and those are potentially life-threatening for embolism, so causing strokes or injuries to your kidneys or gut or these kind of things. So those are two life-threatening ones. But the most common prodrome we see, and it's a big problem in the world, is progressive heart failure symptoms like you're describing.
Right. Thank you. So we're going to get a little bit more into this and the specifics, and we have an animation to play here for you. How does an LVAD help the heart pump blood? Matt, or
Sure. You take it, or, I mean, we can.
Yeah.
Basically, I mean, the common LVADs that we utilize now are, well, the LVAD that we utilize now, I'm holding right here if you can see it. But basically, it has a cannula that sits inside the left ventricle, and it has an outflow graft, and in the middle is the pump. And so what this is essentially a centrifugal pump that spins and accelerates the blood from the ventricle out through the outflow graft to the aorta, as the video was describing. And what that does, it's actually a very aptly named device because it doesn't completely eliminate the ventricular function, but it assists in pumping the blood when the heart's failing, so that prevents congestion, prevents the issues that we were talking about the fatigue and the shortness of breath from the pressure backing up and going to the lungs. And it also improves your forward flow to your kidneys, your brain, the rest of your body, so that you can be more functional.
So getting an LVAD is a huge commitment. Who is the ideal candidate for getting one of these implants, Dr. Danner?
I mean, Ashley, did you want to? This? I mean, it's a complicated process that we go through that really involves a huge multidisciplinary group to evaluate people, and sort of Ashley's one of the experts on evaluation.
I mean, definitely a big component of it is the caregiver support. This is very hard physically, emotionally. It's an entire lifestyle change once you get this device, so it's really hard for people to do it on their own. And we have had patients that have done it on their own, but it's just very, very, very challenging. Mm-hmm. And just with the recovery, and then I mean, Beverly and Larry can speak to it, just your whole life changes. I mean, you now carry this bag everywhere, you have lines sticking out of you, you have batteries, and it's just a lot to get used to. So having good support is very important.
Yeah, absolutely.
And from a physiologic standpoint, you need to have a heart that's failing, and it's ideal that you have a heart that's dilated and you have adequate right-sided heart function. So all of this is evaluated in a big multidisciplinary group, and then hopefully we have the opportunity to offer this therapy.
So these implants aren't brand new. I mean, I think we've heard about the Jarvik 7 many, many years ago. But they've gotten a little bit better since that time, and especially over the past 20 years. How far have LVADs come in terms of survival?
It's pretty remarkable, actually. They talk about Rematch trial, which was 2000s, and that was the first one that looked at the original HeartMate 1 compared to medical therapy. It showed some of the numbers there: 2-year survival of 23%. And then now the 2-year survival from the Momentum 3 trial, which is this LVAD right here, it demonstrates almost 80% survival at 2 years and almost 60% survival at 5 years. So if you think about it in the context of two things stick out to me about how far we've come. One is that if you compare to the actual optimal medical management arm of Rematch, the survival at 2 years was 8%. And now you're talking about almost 80% in Momentum 3. So a device that offers a 10-fold increase in likelihood of survival for a condition, and it's important to remember that advanced heart failure has a mortality rate that is worse than most cancers. It's remarkable in terms of how far we've come. And I think when we talk about some of the recalls later and some of the other things, I think it's important for people to put it in that context, because this is a disease entity that, in the absence of these therapies, the vast majority of people will be dead within 2 years, and we can offer up to about 80% survival at 2 years. So it's a change unlike anything else other than the advent of transplantation in this space. No other therapy that's been put forward, medical or otherwise, has had this degree of impact. And as we all know, transplant, one of my former colleagues at Vanderbilt said that in her book that Lynn Warner Stevenson said the notion of using transplant to cure heart failure or to treat heart failure is like using the lottery to treat poverty, because the reality is that it's a small percentage of the actual people that are diagnosed with advanced heart failure that will ever get transplant. So it's really a paradigm shift in what we're able to offer in terms of patient care.
Yeah, it's truly incredible. It's been life-changing and world-changing, and like Dr. Danner said, there's a lot of people waiting for a heart, and there are not a ton of hearts out there, and there's a lot of associated complications with that. So this is an incredible advancement in this space. So patients like Larry have an implant inside them, plus some other stuff, and you have some of that. I know you elaborated on some of this, Dr. Danner, but actually, maybe you can. There's a controller, there are batteries, a drive line, connect the outside, the inside. Can you kind of explain this?
Yeah. Yes, Larry knows, and he has a bag that carries everything. So for Larry, he has this controller, and this controller is telling the pump what to do. And the controller always has to be hooked to a power source. So he walks around all day with the batteries and this controller. At night, he has a plug-in battery that he hooks up to sleep. And we provide patients with a lot of extra batteries, chargers, wearables. They can always buy their own too. This is about 6.5, 7 pounds. I'm sure it feels like more sometimes, but.
So these are these are two batteries that plug in the controller.
Yep.
The controller plugs into the drive line.
Drive line, yep.
Okay.
Drive line goes back here,
And the drive line goes where?
drive line. So his is on the right side. A lot of patients just in the abdomen, and it just comes out, just a tiny little hole that it comes out of. And a big component of the caregiver role, especially in the beginning, is we teach patients how to do sterile dressing changes. Right. So just how you see physicians on TV, with their gloves and not touching anything, like we teach caregivers how to do that.
Right. So and that drive line connects to the device that's sewn into the heart.
Yes.
Okay.
Yep.
Great. All right. So how much patient education, you alluded to that, how much patient education is there, and how do you make sure the patients and their caregivers are really getting it?
There's a lot ahead of time. We really like to meet patients, as often as possible. Sometimes patients are really sick, so we only get to meet them maybe once in the hospital, and sometimes not at all. But if we can catch these patients in the clinic and show them the equipment, we also like to set them up with other patients if they want to talk to someone that's actually experienced it. And then post-surgery, once the patient's feeling better, a lot of times in the ICU, we're already starting education. And we do it as much or as little as we tailor to each person. Like some people, they get it in 2 or 3 sessions, and some people we have to kind of touch on them every day and just go over things over and over again. And we also have videos and pamphlets we can go, but it's a lot of hands-on.
And that drive line is really important, and that care of that is extremely important, right? Can you explain a little bit more about that?
Yeah, it's a sterile dressing change procedure, so you have to really make sure you're putting your gloves on properly and maintaining sterile technique. And we go over that. I'm sure Beverly remembers going over that.
Yes, I do.
She's a pro now at it. I'm sure she could teach people how to do it now. And it's a very serious thing. And I think that's the thing that people are the most nervous about at first. But once they do it over and over again, and then I feel like our team is really good at trying to provide encouragement and just being a resource to make sure they feel good with it before they go.
Thanks for what you do, absolutely.
Yeah.
Larry, can you tell us, is this a hassle to have all this gear with you, or can you tell us a little bit more about it?
I guess you have to adjust to, like things that you normally do. Now you have to do something a little different. So sometimes it gets sort of heavy, and I take it off and just I'm sitting down on the sofa and stuff like that. But most of the time, I go shopping, the Walmarts, and been out of town and stuff like that. So it just seemed like everyday thing.
All right, great. So you shared some photos of yourself. It doesn't look like you're just sitting at home with this device. You're out and about. Looking pretty smooth there. So, Beverly, did you notice a difference in Larry after you got his LVAD?
I did. It took a minute, you know, like for the healing process and for him to really actually be up and moving around. But I did notice the difference. It wasn't like he was doing a lot of activity, but I noticed he was breathing better. And even his attitude was better because he wasn't feeling sick. So I noticed.
Yeah, it looked like it was. He was out and about. Looking pretty good.
I make him get out and about.
That's good for you, right? So, Ashley, what are some of the biggest concerns or questions that you hear from patients?
I think the main thing is just having something to carry all the time, and just kind of getting used to that. And you know, but we tell patients, I mean, there's almost all things you can still do except for swimming. You know, like Larry, I mean, you guys were partying after the Chiefs Super Bowl and still came to clinic the next day. Like you go out and do stuff. Like we have patients that travel all over the place and still get to go on vacation, see, you know, graduations and things like that. So, you know, it is a big change. So once they get used to everything else, you know, I think a lot of patients find that not too much has changed. They can still do a lot of the things that they used to enjoy.
And they feel so much better.
Yes, and they feel better.
So Dr. Danter, we have some studies showing these devices can extend people's lives. Obviously, you talked about that a little bit. But just last month, the FDA announced a recall for these heart pumps, or some of them, due to some problem with a seal. Can you explain that recall and what it means for patients, existing and potential patients?
Yeah, it's been a bit of a challenging time in the space. There's actually been 2 recalls in the last year for this pump. And I think part of the issue in terms of what Ashley and the rest of the team and myself had to go through in terms of explaining it to people is most people, when they hear a recall, they think they're coming to the place and they're taking it off the shelf. Do you know what I mean? Like there's no longer access to that. And the last thing we'd want to do is minimize the importance of this recall in terms of you know, what it means for patients and sort of minimize it. But it has not really changed the practice because there's no recommendation to not utilize the pump, or there's no recommendation to sort of fundamentally change what we do in terms of approaching patients with this. The first recall is actually related to a problem that has been described with previous VADs as well, which is, it's not this specific one you're referring to, but if you look at the pump, there's an outflow graft that comes here, and for a portion of it, there's a bend relief that effectively protects the early part of the graft from kinking and these kind of things when you do it. It gets somewhat technical. But what they've found is that over time, in a very, very small number of patients, and we're talking thousands and thousands and thousands of implants, there have been 14 related deaths related to what had to be done to correct the problem largely, but compression of this outflow graft by by sort of fibrinous material, clot, these kind of things, impinging on the outflow graft, resulting in low flow. So that was the first one. And so the recommendations for that were for patients were to pay attention to low flow alarms and these kind of things, and as you would anyways, and contact the team and the providers here, and then we'll address it and evaluate it. The other recall, the most recent one, which what you're referring to, was, as you can imagine, this pump sticks into the left ventricle, and what this problem with sealing is, it's hard to show, but there's a very sort of sophisticated clip device that attaches to the sewing cuff, and then you click this in. And what people had been experiencing is, if this is off a little bit or malpositioned a little bit, is that you get air entrainment into the ventricle, because it's spinning, and by what's it called, the effect. Anyways, I can't remember what that term is, but basically there's air that gets entrained into the ventricle, or there's bleeding around that site. So the recommendations for this, again, they're both class 1 recalls, which means they've been associated with patient deaths, and that is not to be minimized, but both of these recalls did not lead to them removing the pump from the market or sort of limiting its use in any way, but basically had us follow the usual sort of policies and the instructions for use that the company gives us to properly attach the device.
So if that happens, do you have to go in and replace that? Or
Well,
what's-
for the first one, there are some things where you can stent the graft from inside, and that's the most effective way to do it and the least morbid way to do it. For the bleeding, for the bleeding and air entrainment, this is something that you encounter intraoperatively. So this is almost always fixed by the time you leave the operating room. And if it isn't, then I find it almost difficult to believe that you could leave the operating room with it,
Knowing the
like
air.
if it's bleeding, you can't leave the operating room with it bleeding, and we all go through a thorough process of trying to get that air if it's entrained out. So the reason why it's relevant is that this device is the HeartMate 3. It has been recalled twice in the last year. None of it has been, none of the recommendations have been to remove this from the market or discontinue its use. And it's different for when this device was recalled and essentially no longer manufactured and no longer offered to people. So although they're both Class 1 recalls, the sort of recommendations from the FDA and from the sort of regulatory bodies are very different. So it's very difficult to translate this to our patient population, but the long and the short of it, I would recommend is that if you have an issue with low flow alarms, you should contact your providers at the VAD center where you are, and they need to investigate it, because there's multiple reasons why you could have low flow alarms. And as I mentioned, this is an exceedingly rare complication that that sort of can require different therapies than a conventional low flow alarm or something like that.
Thanks for explaining that. Appreciate it. So we're here to answer your questions. Please send them in using the info on your screen. That includes chat on YouTube or Facebook, or emailing the Medical News Network. Let's check in with Doc Hawk. Dr. Dana Hawkinson is our Medical Director of Infection Prevention and Control. And right now, we're in the height of tick season. Is that right?
Yeah, we would say tick and mosquito season, actually. So absolutely. There have been, and we'll start with mosquitoes first of all, because most people do get bit by them, and they are just certainly nuisances and pests. So starting with mosquitoes, mosquitoes are the main transmitter of West Nile virus. We should not forget about West Nile virus. For the last 2 summers, KDHE has put out health alerts about West Nile virus. And we also will talk about what is the mosquito that bites. That is the Culex mosquito. It does bite between from dusk to dawn, and definitely so in that nighttime period. Why is West Nile virus so important? Well, only about 20 to 40% of people, Sean, may have some fever. 20 to 50% may have a fever and rash. Most people are asymptomatic, so they don't even know they have the infection. However, we should mention 1 in 150 people who are infected will develop severe CNS or central nervous system disease, things like encephalitis and meningitis. And so in Kansas, what we saw in 2023 is that there were a total of 65 human cases that were diagnosed by laboratory. 46 of those were neuroinvasive. What does that mean? Does that mean that we don't have very many numbers? No, in fact, I would say we probably have a lot more numbers than we know, only because of the fact that really 1 in 50 do develop that neuroinvasive disease. So if we have at least 46 accounts, we can imagine all the other people that are walking around with the disease may feel a little ill or may not have any symptoms at all. So it can be a very big burden. Next, we have ticks. So ticks are extremely important, and we know that a lot of people are out in rural areas or working outside and have a lot of contact with ticks. It is very important to understand the amount of disease and the disease that can be spread by ticks. So KDHE recently put out another health alert, and they said that from the beginning of the year till now, they've had over 200 lab reports of disease. Now, there are different diseases that can be spread by ticks. Those include ehrlichiosis, Rocky-Mounted spotted fever, a couple different viruses such as Heartland virus and Bourbon virus, and most recently we have had a recent fatal case of Bourbon virus around here as well. These diseases are spread by the Lone Star tick. This is opposed to the deer tick, which can spread Lyme disease. Again, the other diseases I talked about, such as Rocky Mountain spotted fever or ehrlichiosis, those are more common around here than Lyme. Most of the cases in Lyme in Kansas that we see are travel related. We do have the deer tick around Kansas, but not as much, and the deer tick is what spreads Lyme disease. So I know that a lot of people see a tick and they automatically think Lyme disease. Well, we really don't have a lot of that around here. In addition, when people are outdoors most of the time and the tick disease burden is the highest, really those deer ticks are not really feeding on humans at that point in time. So there are other diseases that we need to be aware of and we need to evaluate for, and I think that's very important. So how do we protect ourselves? Well, against mosquitoes and ticks, it's a lot of the same prevention. It's wearing long clothing. It is wearing the insect repellent, and it's insect repellent with probably the most common substance is DEET. But you can also treat your clothes with permethrin as well. So those things can help you avoid getting bit by mosquitoes or ticks. They both work very well. There are websites, the EPA website, but also the CDC website will help you identify what are the EPA registered repellents to help protect you and where those substances. Again, DEET is probably the most common one that we are all aware of, but there are other substances as well that work well as insect repellents also. So again, prevention is the best thing.
Great. Thanks, Doc Hawk.
Yeah.
You caught me with their feeding on humans. They caught me there.
Well, and I would say, too, that the mosquitoes that do transmit West Nile, they prefer birds. And so that's why when initially we saw West Nile virus in the United States in 1999, it was a lot of bird death. If there aren't birds around, they certainly will eat on other hosts, mammalian hosts, including humans as well. So,
Right.
yeah, that's what happens. Unfortunately, we are always in a war with the world around us.
Thank you. Appreciate it, Dr. Hawkinson. We want to show you, give a quick shout out to the doctors in this photo. These are 4 out of the 5 health system sports medicine experts that also work with the Chiefs. Doctors Luke Thompson, Paul Schreppel, Brian Vopat, and Scott Mullen visited the White House last week with the Chiefs for the Super Bowl ceremony. It's not their first time there, and we hope it's not their last. Congratulations. Alexis Del Cid is watching for questions from our community. Alexis?
We have a good question from Jeremy. Jeremy has a question for Larry. Larry, Jeremy asks, what was the biggest adjustment you had to make in your day-to-day life?
Well, I guess, just adjusting to, activity, being active, going dressing and, the whole total thing, just like adjusting my whole life to where I was normal to, where I was used to something else.
Gene has a question. He would like some clarity on how you get the device into the chest and how long the procedure takes on average.
Dr. Danner?
It takes as long as it takes, I guess is the simplest answer. So there's a couple of approaches that are utilized for putting in LVADs, and the one is a relatively limited approach where you use an upper sternotomy or a thoracotomy on the side, and then another thoracotomy on the left side of the chest, and the pump is essentially sewn into the left ventricular apex with a sewing ring placed right on the apex. Then you core that, stick the pump in, and then attach the outflow graft to the aorta. The most common way it's done in North America is actually through a full sternotomy, just like regular open heart surgery, and you go on the heart-lung machine, and that's the approach, the approaches that are utilized.
Stuart wants to know how many people are living with these devices right now?
Our pool, Ashley, is...
We follow 109 patients. Worldwide, I believe it's because these are implanted all over the world, in the tens of thousands worldwide. But yeah, and we just implanted our 300th VAD.
And our 301st.
Yeah.
All right.
Yeah.
Yeah.
For the program history. So it's yeah, it's a like we said, it's a revolutionary therapy, and it's really sort of changed the landscape.
I have a question for Ashley, because I can't help but notice you're wearing that pin. I love LVADs, or I love VAD.
Yeah.
And when we invited you onto this program, you were so excited. I think you said, yes, please, I'm passionate about this. As an RN, how did you discover that this was your passion?
Well, I worked on the post-surgical unit when the program started, and I was part of the first group of nurses that were kind of trained to learn how to do this device. And I just really liked how it's very complex but very simple, and once you get used to how it works. But I just love that patients that may not have had a chance to live, they have this device, and like Larry got, he's 6 years on this, and it's just amazing seeing them from the inpatient side, or even before, and being so sick, and then now just going out and about and probably more active than I even am, So it's been a really great, it's a really great type of nursing, just to kind of see that progression in patients and just see them just do so well, because these, like Dr. Danter said, I mean, these patients are very, very sick, and so it's just nice just to see them be able just to live normal lives like nothing even happened. So it's great.
Marie has a question. What if there is a problem with the LVAD? Even worse, what if you're a restless sleeper and you toss and turn and you get up a lot at night? Could that cause a problem with the device?
Yeah, and we do a lot of training on that. How to wear your equipment. We even talk about how to wear it when you're sleeping, and if there is a problem, we do have a great team of doctors and VAD nurse practitioners. We have someone on call 24/7, and we do a lot of training with our patients on any time, day or night. If you have an emergency, to page that number, and we can troubleshoot and help you out with that. And then just basic needs during the day, if patients have trouble, like, oh, I'm gaining a little weight, or I'm just not really feeling well, they can call us too. So it's it's a very close-knit group of providers and patients, and we really stress to them, like, please call us. No problem is too small. We'd rather you call and not be something than just ignore it. So we do a lot of education on that.
A follow-up question from Marie. What are the LVADs made out of, and how does the body not reject a foreign object placed inside it?
Well, they're basically stainless steel and composite metals with basically outflow graft that is Dacron, and the driveline is coated in velour and to sort of stimulate ingrowth. Rejection is an interesting phenomenon, right? It's not uncommon that we get this question, but rejection is an immune-mediated response. This is not per se immunogenic. It causes inflammation, and it could cause a local reaction from inflammation around the pump. But in terms of stimulating your body's immune system to identify this as not self, this doesn't have the requisite sort of makeup to stimulate that part of the immune system that causes rejection. So just like you don't reject a metal hip or a metal knee, you don't reject a hunk of metal sticking in your heart. That's different than, say, some of even the early tissue valves and things that were utilized for valve surgery, where even though you treat them to get rid of all the immunogenic properties of that foreign tissue, the body still can identify that as not self. This is different in terms of it. The mechanism of there really is no mechanism of rejection for the stainless steel and metal.
So no anti-rejection immunosuppression
No
medication.
immunosuppression medications are needed. Basically, we're working on minimizing anticoagulation basically now. But it's not a phenomenon that causes any rejection.
All right, thank you. Well, this has been a really awesome discussion. We want to get some final thoughts from our guests. Beverly, we'll have you start off with final thoughts.
It's, it took some getting used to, but now it's like just a normal, everyday thing. He's been doing it so long. He does his own treatments. At first it was like you had to bow breathing. Hey, the sterile technique. Okay, you can't do this, you can't do that. But
Sterile
now
bow
he does it
breathing.
himself.
Okay.
Every now and then I may go in and help with a little something, but I'm comfortable with, because it's, and he's still here.
Yeah.
So.
Larry, any final thoughts?
Well, I could say, I've learned so much through Bev and stuff like I do my own medicine and everything, so I know whatever pill I'm taking, so it is, like say if I go somewhere, I say, well, one pill is missing, I say, oh, I got to go back and get this other pill. So it's being confident to know I can take care of myself. Yeah, it makes me feel good.
That's great.
I do leave him at home sometimes to take care of himself. I go on vacation by myself.
You get a pass. Ashley, final thoughts?
Yeah, I mean, it's great to see, I talked about how a caregiver is so important, I think, especially in the beginning, but, eventually patients are, a lot of them, able to just do things on their own and just live life completely normal. So I just think that I do love LVAD. I will always wear this pen. I just think that this is a wonderful, wonderful therapy, and I just love seeing and hearing patient stories, and I'm just really, really proud to be a part of it.
Right. Dr. Danner?
Yeah, likewise. If you think about it, being a heart failure surgeon, say it was 40 years ago, you had medicines and transplant. And now you have this technology or technologies like it, and what's coming down the road, hopefully, to make this a more applicable, therapy for people. I think if we speak to the justifiable patient angst about these recalls, I think the most important thing to do would be, if you have an issue or you have questions, call and ask us, because what I would hate is that people see a headline that describes something, don't read the entire article or read the entire recall to see what it actually means, and then think this therapy is bad, because there is no other therapy in surgery that I'm aware of, other than, say, cataracts and taking out people's appendixes and these kind of things, that takes your survival at 2 years from 8% to 80%. And that is what I would hope the take-home message would be about this therapy, because there are literally tens of thousands of people in America right now that think, I'm just getting old, I'm just getting short, like it's normal to get short of breath with this kind of stuff. None of that is normal. And the therapy should be able to grow because it is extremely effective, but people need to be aware of the symptoms and not unduly scared by some of the press that's out there and some of the things that are said about this therapy, because not everyone's going to be transplant eligible, and this, as you can see, is a fantastic therapy.
Thank you. Yeah, I think we've been talking about something here, the groundbreaking things that happen every day here at the University of Kansas Health System. My only ask is, if you're not feeling well, see your care team. More importantly, as we've heard today, your family, your friends, your partners, they see things before you. So please listen to them, seek out care. We're here for you. Thanks everyone for watching and listening. Dr. Stites will be back next week. Have a great day.
Coming up Friday on the Morning Medical Update. Shay Franklin was told she had, at best, 4 years to live. 15 years later, she's living a full life thanks to CAR T-cell therapy. I'm Jessica Lovell on the next Morning Medical Update. How the cellular therapy has improved even since Shay's diagnosis. Plus the new FDA approval giving more patients access. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.